Even permanent, we will give molar. At the time, the bone will be formed nicely. At the time, you can place one more extra implant and you can do it. But the basal bone is good. The X-ray doesn't cover the lower end. Definitely, it will be more than 14, 16 mm we can place. We'll place one more implant in the first premolar. First premolar also looks good, but we don't know how it looks inside. Just we will check with the second premolar. This is the mesial root of first molar, right? Definitely mesial root of first molar is not ideal. This is distal root. Distal root looks quite okay, right? Palatally we can, lingually we can tilt and go. This is the interdental bone. Interdental bone looks good. This is the nerve. We can place implant. Now we are going to mesial root of 7. You can try lingual cortical engagement. A single implant lingual cortical engagement is enough. This is the distal root of 7. So here, either the interdental bone or the mesial root or distal root all looks good. This is the distal root of 7. Definitely, I will place a basal here. Okay, because here a lot of infection granulation tissue is there. I can place a basal design. Around 15 it shows, 14 mm implant we can place. I am including for soft tissue thickness also. You see here the value is around 900, the lingual cortex. Actually, this is the very easiest implant you can do because the mylar attach is very much superficial. You can easily just drill through the root along the lingual wall and straight away get lingual cortical engagement. The nerve is for it. The only trouble, only challenge will be the inter-implant distance will be more. So better we can place the implant in the mesial root of second or in the interdental bone between 6 and 7 and one more implant in the distal root of 7. 2 implants in the distance. This is the 3-2 area. See the lingual plate is very good, but buccally there is severe bone loss. If I want to make it even, I have to reduce this bone till this bone. If it is too much, then what I do is, I may be doing only till alveoplasty here. I will select a BZS here now. Okay. For the sake of placing a compressive, I don't want to do extensive alveoplasty. If I want to do KOS, compressive implant, I have to do alveoplasty. If it is too much, what I will do alveoplasty only till here. And I will place in, this part will be without bone. No problem. Okay. So this is one situation. Actually, this is only one of 2 or 3 situations where we can use basal.
But over here, or later on, after the resorption pattern, will this be exposed or it will be covered with gingiva? Here, this
will be covered with gingiva. Even if it is neck part is exposed, that is not a problem. It is smooth surface only. It is not going to attract rough part. If the rough surface is exposed only, then it is a problem. It will keep on retaining the bacteria. Then the bacteria may infect the gums and bone pericarditis and all. So it is a smooth surface, it is not going to attract or retain or cultivate the bacteria. So the reason why our toilet, their ceramic surface smooth and polished. Why they make smooth and polished? Because the bacteria cannot grow over a surface which is smooth. Only rough surface. See, most of the time I will do alveoplasty, no question, compressive. But if it is too much. So this is first premolar. You can see the lingually very thick bone, buccally no bone. So you have to drill more here, otherwise our implant will come very much buccally. So we will see the 5 here. Also looks good because we will see the mental foramen. See here you can see the double mental foramen. Right? Some kind of double foramen is showing. It is almost more than between mesial and distal root. So you can place implant in the second premolar area also, right?
So that means like always we cannot predict it will be in the between the premolar. So always we have some cases.
Straticide is mostly between below the second premolar. Some certain cases between.
This pattern is due to the extreme resorption.
No, it is not due to resorption. See, the height from the crest varies due to resorption. The more the crestal bone resorbs, it becomes closer to the crest. But the mesodistal position is something genetic. It doesn't change due to any disease.
Another one also, I told you about the 8 years patient. My mobile.
Which one?
Mobile. Back there. But we didn't do that. I told you 8 years patient on a conventional patient was
90 years, but the patient was.
Yeah.
See the axial view. See the bone loss. So now we can see better. So this is a lateral incisor. Lot of length, up to 16 mm implant we can place. This is second premolar. You can see, no? This is second premolar, but the mental foramen is below the percussion level. So you can place the implant even in the second premolar area. Of course, a short implant. Here, the lingual bone is present, but there is buccal resorption. We try to do alveoloplasty, or if it is too much, we can select it. Just in the first premolar area where the buccal bone is thin and lingually it is thick. We will see the distal root of 6. Okay. We can place along the lingual wall. Okay. 3.75 10 will be fine. We will see second molar area. This is a special case where we can place implant in the second premolar. See, the problem in second premolar is there is severe bone loss. Okay. So this is the first premolar. Better we can place a basal implant, basal design, because already there is severe bone loss. Okay. If you want to place a compressive, then we have to remove this part. Okay. So left side is comparatively looks quite easy. The right side is the troubled one. We will see. The main challenge will be arresting the bleeding here. Okay. See, if we remove the granulation tissue, what happens? Below the granulation tissue, there will be vessels feeding the granulation tissue. So those vessels will start oozing very much. If you are not removing granulation tissue, we cannot see the anatomy, we cannot drill it. So this is a problem. So if we are removing 7 now, we won't do any granulation tissue removal. Unnecessarily we are troubling. We just place implant in 7 and we stop it. But here we need to remove granulation tissue. Definitely there will be a ooze. So we'll start.